Thank you. Perfect. Thank you. Good morning, everyone. So, how did you sleep? Who had a good sleep? Can you please let me know? Perfect. Excellent. Usman, you are the executive director. Did you have also a good sleep?
Yes, I did indeed. Thank you very much.
Perfect. So you had better sleep than yesterday, right?
Yeah, absolutely. I think the whole of the secretariat did.
In fact, I asked most EPF staff, and they all told me they had a better sleep tonight than yesterday. They're all relaxed, and everything goes fine, and this Congress is really a success, so they sleep really well. Good. Okay. I've seen Lars running, doing some jogging in the morning or running, but I also have seen you're running with a bunch of people who are running only 5 kilometers, with Ida, for example. Where is Ida? She was organizing the other group. Yes, okay. So how did it go? The 10K guys with the 5K ladies running together, how did it work out?
Well, I'm here. So
yes.
We got back.
Yes,
that's a good point. But yes.
Big applause.
Well.
Okay, 10 kilometers running in the morning. Excellent.
And I think we kept our pace levels to everyone's sort of. I'm not sure the right word is satisfaction, but at least that they're all alive.
Good.
I think.
Okay. So a big applause for those who were running again. Ida, Lars, and some others. They organize it on Hoover, so it's a good platform. Okay. Now my question is that most of you had a good sleep, and please think for 10 seconds, what is the sentence that you bring over, the message that you bring over from yesterday to today, right? So when you woke up, maybe you had an idea, the first idea, and what was that idea? Please just spend 10 seconds and think about it. You'll have to share it soon with your kind of neighbors here. 10 seconds. Most important idea that you're bringing over from yesterday to today. My idea was, by the way, what Sarah was mentioning. You mentioned yesterday in your presentation, that more experienced patients should be mentoring less experienced patients. And I thought there is so much potential in this message, so this was the first thing that popped into my mind this morning. Okay, Moir, for example, what is your idea that you bring over from yesterday?
I think the most important thing for me was for both Case and Sarah, who said that we need to get a balance between healthcare and self-care. You can write a poem out of that if you wanted to. But that was important to me.
Very important idea, thank you. Usman, for example, what is your sentence?
And you gave me more than 10 seconds. 20
it's
seconds.
True.
I've got 20 seconds. I'd go back to Marco's opening comments, and I felt that the whole day was us trying to walk on the moon. And it was lovely to see. We were getting out of that space capsule and trying to walk on the moon, and we need to continue to do that.
Very good. Okay, thank you. So please, I hope you have already this idea. Please turn around and spread your idea to at least 2 people, right? Your sentence from yesterday. Find somebody and just let them know, your bright, fantastic, fresh idea this morning.
Presentations from yesterday and from today. Are they on the website?
I think so. They will be available. I think so,
I
yes.
got lots of information, but as I don't only my native speaking, take some time.
Yes. Yes. So at least to 2 people, right? So 1 person and second person. Share your ideas at least to 2 people. Turn around, find somebody else. What's your idea? You have to do it. They wait. All right. Thank you very much. Okay, so we have to close this little session. Thank you very much. Oh, wow, it's amazing. Everybody keeps talking. Fantastic. Please, please. It's fantastic. Please, it's fantastic. I mean, it was already a fantastic session. Thanks for sharing. Thanks a lot. Thanks a lot. Great session. Okay, so I give the floor to Moir and she'll do a bit of housekeeping.
Okay, I need everyone to listen to me. This is important stuff. To remind you that there is no fire drill planned today, so the exits are over there, and then 2 in the back, and we meet in the plaza if there is a fire, if the fire alarm goes off. We are live streaming everything today, and there are photographers and camera people going around. If you don't want your picture taken, let one of the EPF team know. If you are an avid Twitter person, a tweeter, please use the hashtag EPF Congress 19. Please be engaged. We are live tweeting everything. And Emily in the back there has got a big sign, and it's all over these screens when they're kind of not looking at me. I also need to thank, on behalf of EPF, everyone who is partnering with EPF to do the work that they do, and also the sponsors for this Congress. There's a big thing in the back there that tells you about them all. I won't name them all because I don't have a lot of time. I think that's everything for me. I think we can kick off.
So the next session, the title is Ensuring Equity, Inclusivity and Diversity of the Patient's Voice. And this this session will be chaired by Nicola Bedlington, who is now currently a special advisor of EPF, but in fact, she became the Secretary General of EPF in 2006. And you established the secretariat, and you have been working in this position until April this year. So congratulations, you are the kind of the historic person of EPS. So please come on board, floor is yours. Thank you.
Thank you very much for that kind introduction. It just means I'm very, very old. So I'm absolutely delighted and very proud and honoured to be chairing this session today. It's a really, really core subject for EPF, equity, inclusivity, diversity of the patient's voice. And we have been doing some work on this over the years with our fellow social NGOs here in Brussels. We developed a roadmap on the topic. We're also part of the social platform. And as we heard yesterday, the Sustainable Development Goals are hugely relevant also in the European Union space. Goal 3 on health and our strive towards universal health coverage. And the other very, very important premise around the Sustainable Development Goals, never leaving anybody behind. And this is really the essence of our session today, to look at how we can really make sure that groups that are vulnerable to exclusion and stigma can be part of the patient's movement. So without further ado, to set the scene, I would like to invite Professor Jan de Messner to the floor. Jan has a distinguished career, both at national, European, but also at global level, and is particularly well known for his fantastic sterling work in the area of primary care. He's also the chair of the expert panel that's looking at effective ways of investing in health and advising the European Commission. Has done a whole rack of work. Always, thank you, Jan, including the patient's perspective there. So a very warm welcome to Jan to set the scene, and then we'll be following that with a panel discussion with lots of representatives from vulnerable communities. The floor is yours, Jan.
Thank you very much. It's absolutely a privilege and a pleasure to be honored and invited to speak to a patient group, being myself an academic and a healthcare provider. I'm a family doctor by training, and I worked for 40 years as a family doctor. And by time and wide, but fortunately, not too many times I'm a patient, but I'm a citizen, and I feel very much solidarity with what matters to patients. In this talk, I want to try to give you a view at different levels, where all these things that we discuss, equity, inclusivity, and diversity, play a role from a patient's point of view. We will start at the nano level, which is the individual interaction between a provider and a patient. Then we go to the micro level, which is a team, the meso level, which is the population, and the macro level, which is the policy and the big decisions. And of course, at the nano level, I think that's a very important thing. If you ask a patient, how was your stay in the hospital? He or she will tell you, the nurse was nice and she listened to me. The doctor looked at me, and the person at the reception, she had an ear for my questions. Because that is what matters to people, the direct interaction at the nano level between two persons. That is what determines for them the feeling of quality. And so at the nano level, access is extremely important, of course linked to quality. Inclusivity, already was said by Nicola, nobody should be left behind, and diversity, which includes the human rights and ethnosensitive approach that we today we want to go for in our provision of healthcare. And when it comes to access, with the expert panel, we made an opinion where we looked at the different dimensions. I'm not going into detail, but it's about coverage and affordability. It's about availability of services. It's about timely availability when it is needed for the patient, and also this leads to equitable access of health care. All these elements have been discussed in detail in the opinion, but I want to just especially emphasize the undocumented people. In many countries, like in Belgium, we have a regulation for undocumented people, and I think that this is very important. Every human being counts, and there is not an illegal person. A human being is always legal because he is a human being, and I think that's very important. When it comes to this interaction with the individual provider, I think there are essential things that we all value as human beings and as patients. It's about commitment and connectedness, creating connection. It's about the clinical competence of the provider that you are expecting from the patient perspective, but also the cultural competence to see the context of the way I'm living as a patient. I want the provider to have interest in that, to look at that. Comprehensiveness, not only looking at my body, but also at my mind and at my aspirations. Dealing with complexity. Care is complex, and we should not go away from that. It is what we should embrace. Coordination becomes more and more important due to the complexity, and continuity of care, and especially the personal continuity, I think, is so much valued by patients because it's so essential. And of course, we have challenges, be it the dilemma between compassion and computer, and I think in modern healthcare, that's absolutely something we have to face. So what could be the role of patients' organizations? I think certainly at the nano level, it's about advocacy. It's about strengthening people and increasing health literacy so that people have better possibilities to interact with healthcare system and healthcare providers. It's about empowerment, having the feeling that you've got your life under control, that you've got something to say. And of course, there's a very strong tool that patient organizations have to put this on the agenda, and the narrative of patients' experiences. And I think that's what we should use very much in order to make sure that people pay attention to this. Let's go a step further now to the micro level, the team. And of course, also there, when we have an integrated interprofessional team, access is an important thing, and coordination should be very much looked at. And inclusivity and diversity means that I think we should shift to goal-oriented care, starting from the life goals from the patient. And I just want to mention that the expert panel on effective ways, when it defined primary care, it added a special sentence saying these services, primary care services, are delivered in a sustained partnership with patients and informal caregivers. I think this was an important feature of this definition because it drew the attention on the central role of patients in this, and that the team around should take care of this central role and give it the space that is needed. I had the privilege to work for 40 years as a family doctor in a community health center in a very deprived area with all kinds of healthcare providers, dentists, community health workers, social workers, dietitians, health promoters. We took care and we take care of 6,200 patients. They come from 95 nationalities. So every consultation today is a journey around the world. And I think this really requires a new kind of perspective of healthcare providers. One of the important challenges is, of course, today that we go from monomorbidity to multimorbidity. We see more and more patients with multiple problems, and I think that is on the agenda today. Here you have a look at people that have 0 disorders, 1, 2, 3, 4, 5, 6, 7, 8. And you see with increasing age, the number of people with multiple conditions increases. And I think that will be the feature that characterizes the care in the future most. And what we see also is that for every single age group, there is more people in the lowest social class with multimorbidity than in the highest social class. So there is a clear social gradient, and I think this is a double challenge that we are facing now in our care process. And of course, we build wonderful health systems, you know that, and that has been discussed certainly yesterday, with self-management support, with delivery design, with decision support, clinical information systems, in order to have this kind of informed, activated patient that can interact with a prepared, proactive practice team. And of course, to make that happen, we have to empower the patient, and you see it's very easy. The patient becomes already stronger on this picture. So that is what we should aim at. But unfortunately, when I look at this from my perspective here, I see something different. I see that very often the system does not fit with what matters to the patient. And I think that's one of the things we are facing today. And I just want to share with you a story of a patient, 75 years old, with 5 different conditions. Operation for coxarthrosis, hypertension, diabetes, COPD, osteoarthritis, and so on. The traditional patient we see today. She lives alone, she has some help from her daughter, and I go regularly there as a family doctor, and the patient, each time I visit, says to me, "Doctor, you must help me." And then follows a succession of complaints and unwell feeling. Sometimes it has to do with the heart, another time with the lungs, and then the hip. And each time I suggest, according to my guidelines, all sorts of examinations that do not improve her condition. Her requests become more and more explicit, and my feelings of powerlessness, insufficiency, and spite increase. Moreover, she has to cope with guidelines that are contradictory. For COPD, she sometimes needs corticosteroids, which worsen her glycemic control for diabetes. The adaptation of the medication for the blood pressure, one time too high, then another time too low, cannot meet with her approval, as does my interest in her fast hemoglobin and lung function. After so many contacts, the patient says, "Doctor, I want to tell you what really matters for me. On Tuesday and Thursday, I want to visit my friends in the neighborhood and play cards with them. On Saturday, I want to go to the supermarket with my daughter. And for the rest, I want to be left in peace. I don't want to change continually the therapy anymore, especially not having to do this and to do that." In the conversation that followed, it became clear to me how this patient had formulated the goals for her life. And at the same time, I felt challenged how the guidelines could contribute to the achievement of Jennifer's life goals. I visit the patient again with pleasure ever since. I know what she wants and how much I can merely contribute to her life. Ladies and gentlemen, do you know Jennifer? I think we know them all. I told the story in all the continents, and Jennifer is all over the place. And if you add up all the guidelines, then you come up with this, what the patient has to do, clinical task, what the doctor has to do, patient tasks, we're not going to detail, patient education, it's all evidence-based, referrals, and then 22 intakes of 11 different medications. The question is there life apart from the disease for this patient? And I think that's really the challenge. And already in 1991, Jim Mould wrote this wonderful article on goal-oriented medical care, where he said we should define the goals, start from the goals of the patient as the maximum desirable and achievable quality and quantity of life as defined by each individual and not as the absence of disease. Measures of success are the achievement of the individual goals and not only the accuracy of diagnosis and the appropriateness of the treatment. And the evaluator of success is the patient. And I think this shift, this paradigm shift, is of utmost importance. And what really matters for patients is to be able to function and social participation. And maybe you are aware of this booklet as the International Classification of Functioning. Well, I think it will become in the future for care more important than the International Classification of Diseases, because that is what matters to people. So we want to put the patient centrally in the process, shifting from disease management to participatory patient management, starting from the life goals. Unfortunately, our system is still very fragmented and siloed. We have different programs for hypertension, for COPD, for osteoporosis, diabetes, and so on. And I think that this is really a challenge for a patient, because At the patient level, you have the integration. You need the integration of this. And this kind of vertical programs very often create duplication. Patients have 3 visits a week. It's not integrated when they have 3 conditions. There's very often inefficient facility utilizations, tests are redone, not well coordinated, and there is inequity between patients. The inequity by disease is, I think, a major challenge because nowadays it makes a lot of difference if you have hemiplegia due to cancer or you have it due to stroke. In some countries where there's a cancer plan, you will have huge differences in care, and I think that's an unacceptable inequity. And so we need to integrate this implemented in the context of a strong primary healthcare. And I think that primary healthcare is where the patient really can realize the integration. And so we will deal more and more with interprofessional teams and interprofessional discussions, and I think the patient should be there. And the patient is sitting here, is attending the meeting, or a representative of the patient to listen to what's happened and to participate in the decisions. And another important thing is, and in a recent report by the OECD, it was said, flying blind, and that is the issue of how do we integrate the information in the medical record. And I think we have to evolve towards a new type of medical record where we start centrally from the patient personal life goals. And these are formulated by the patient themselves. And then we can link different objectives of the patient that are shared between patients and providers and see how these life goals can be achieved. And then you bring the information of the health problems into that. And you see how the approach to the different health problems can contribute to the achievement of these life goals of the patient. And you monitor that. And you see with different tools how this can be realized, what are the barriers, what can be facilitators, ending up with an action plan that is shared by patients and by providers. I think that this should be the redesign of our electronic patient record, really starting from the patient personal life goals that are filled in by the patient in our health self. I hope that one day somebody will start to develop this idea. So that means at the level of the micro team, that it is important that patient organizations try to participate in the organization of the care process locally. I think patients have an important voice there to give. That patient organizations should advocate for outreach to vulnerable groups. That patients should be in the driver's seat when it comes to care coordination. Mobilizing citizens to provide support in the care is also important, and to strengthen informal care, informal caregivers. And finally, participation in local policy is a very important other element at the local level. And all kinds of initiatives can be done at the individual level, at the group-based level, and when it comes to health promotion. And you see some examples here, for instance, patient initiative and intercultural diabetes breakfast, in order not only to cope with the disease, but also to create connectedness in society, was one of the initiatives that was taken. When it comes to the MESI level, of course, equity means that the system should be accountable for a defined population. In many countries, we organize now primary care in relation to a defined population, 2 or 3 communities, a city, some villages together, and so on. When it's about inclusivity, it is important that it's not only looking at the health system, but that we look at local level at intersectoral action for health, because there are so many social determinants that play a role. And when we address the social determinants, it's important that we follow Sir Michael Marmot's advice to act from the perspective of proportionate universalism. And that does mean that it implies a need for action across the whole of society, focusing on social factors that determine the health outcomes. And in addressing health inequity, the strategies that should be given priority are those that are universal, but are resourced and delivered with an intensity that's related to the level of social need. And if you look at the 2 pictures, the one is about equity, and you see then some of the people even don't see what happens. And the other is about equity when you adapt and facilitate the conditions of living so that everybody can participate. And I think that's an important principle. More and more countries now, like Estonia and regions, start to organize these primary care zones where they organize the primary care providers together. Some were at 100,000 people, sometimes at 200,000 people. But I think it's important that this is a way where patients also can act on the primary care level and raise their voice. And of course, patients have to choose freely where they go, but not only for individual providers. More and more we see that they choose for networks. And that's why it is so important that patients can participate in the way those networks interdisciplinary are organized. And of course, also at the local level, it is more and more important that the patients have an active voice. In the region of Flanders where I work, we now have installed primary care zones, and there is a board of 24 people. 9 out of the 24 are under control of the patients. 3 are patient representations, or organizations representatives, and 6 are out of the local authorities. Of course, there the citizen has his vote and contributes to the composition of this group. And I think that's important, that this way integrating primary care, public health, social sector is really a way to look forward. And also this enables to work with the community when we look at health problems at community level, and we can look at the upstream causes that very often are dealing with traffic safety, with housing conditions, with working conditions, and so on. So voicing the local needs of patients is extremely important for the patient organizations about access, and also intersectoral cooperation, working together with other actors, and especially also looking at the importance of working together with civil society organizations and other groups in society. We come finally at the macro level, which is about the integrated health in all policies approach. Human rights, advocacy, solidarity and social justice and democracy are essential values in this approach, and we should never forget that health is global. And of course, patient participation is a spin-off of the emancipatory May '68 movement. I was 16 at that moment, and I was very much active as a student in that. And I think that they're still very inspiring, but there are important challenges. And one of the challenges is that we face now is the affordability of payment for innovative medicines. In Belgium, we were confronted with a case where 1.9 million euro was the price of one injection for a certain disease, SMA. And of course, it was solved by crowdfunding because there was not reimbursement, but that's not the way to go. We have to strengthen solidarity. And that means that we have to interact in a dialogue as patient organizations with pharmaceutical industry, thinking about new ways of working, delinkage, research and development on the one hand, and production and sales on the other hand. This will create an environment where probably we will be able to make the medication that we need at affordable prices. Price negotiations should not be at country level, but much more at EU level. Co-payments should be reduced or in any way fixed or completely eliminated. And we have to rethink the managed entry agreements that bring now medications on the market, because I don't think this is a sustainable system. Patients have a very important role to participate in this debate and to make change happen. There is now also more and more evidence, and the Lancet contributed to that, that democracy is good for health. And I think we should not forget about that. I think it's a very important message. And so, as a patient organization, we have interest of strengthening democracy all over the place, because there is evidence that when regimes become more democratic, this has positive impact on the health of the populations. So it is good news that democracy is good for health, and that can motivate us to work further. But health is also global. And with the expert panel on effective ways of investing in health, we did a brainstorming, and we dealt with the problem of Africa. There is no future for health in Europe if we not engage in a new dialogue with Africa. I'm pretty convinced about that. So migration and refugee crisis, climate change and capacity building for healthcare, education, food production. In the global south, they are strongly interrelated. And the European Union could address these issues in a more integrated and comprehensive way, looking at push and pull factors, socioeconomic and ecological drivers. And this requires the European Union to take a leading role in a new dialogue with African countries. This should be operationalized both at research and at developmental aid and capacity building level. I think that the patient voice is essential. And I would really encourage to link up with patient organizations and citizen and civil society organizations in Africa to discuss the issues globally. What could be at this level the organization of the patient's role? Of course, policy participations all together, patients with civil society organizations and committed critical academics That, for me, is the golden cocktail to really give strength to the patient's organization and the patient voice. It's also very important that patients can participate in defining and designing the research policy because they have really a voice and they know what should the priorities be. With the European Forum for Primary Care, we have integrated the patients, we have all disciplines there, and we are very happy that we could integrate also EPF, and it's now represented in our advisory board, so that we have really all the different stakeholders together to discuss at European level the future of a strong European healthcare system with a strong primary care. And we will look in our next conference at diversity, and that's linking with the theme of today. Ladies and gentlemen, I hope I could give you some ideas about what, in my view, patient organizations as important partners can contribute at different levels in order to achieve the goals of equity, of inclusivity, and appreciate and respect diversity, because that is what will make our societies healthy and sustainable. Thank you so much.
If you'd like to go and sit at the end, that would be fantastic. That was a very wide-ranging presentation covering so much ground. Obviously, the starting point are the goals of patients themselves, solidarity, the big challenge of multimorbidity, social determinants, Michael Mormont's work, of course, but also the idea of patient organizations as agents for public health, looking at the whole prevention space. Lots and lots to think about. I would like now to invite the panel to come up to the podium, and we'll kick off the panel discussion. I'll invite the panelists to make a few introductory remarks, and then we'll open the floor to all of you. So while you're listening to the comments of the panel, think about perhaps questions and reflections you might want to add. And I'd like to kick off with you, Chris. Chris Roberts, Vice Chair of the European Working Group of People with Dementia from Alzheimer Europe, which is a founding member of the European Patients Forum. Chris, how can we ensure the voice of people living with Alzheimer is heard within their representative organisations? And is there any good practice that you can share with us from Alzheimer Europe's work?
Oh yeah, absolutely. The European Working Group was launched by Alzheimer's Europe and member organisations in 2012. The group is composed entirely of people living with a dementia diagnosis, not all being Alzheimer's. There are over 200 causes that contribute towards the dementia syndromes, such as FTD, Lewy bodies, PCA, etc., etc. We are comprised as a group of a minimum of 10 people, all from different countries to a maximum of 15 people. Alzheimer's Europe supports the travel, accommodation costs of the members and the supporters that accompany us. The working language is in English, and we are nominated by our national association members and associations, societies, to ensure that the activities, projects, meetings of Alzheimer's Europe reflect our priorities and our views, that the people with dementia that they're working for is included. The group operates independently, but with the help, support and facilitation from our two Alzheimer's Europe project leaders. These two ladies really get it. They understand what dementia is and how it impacts on our lives. We all together then look for solutions and not dwelling on the problems. Our membership elects their own chair, vice chair, and we set an agenda of activities for the current year. The chairperson also sits on the board of Alzheimer's Europe. This is full inclusion. It's fantastic. We actively participate in Alzheimer's Europe annual conference, but not just speaking at the conference. We chair breakout sessions. We design and hold our own symposium where all the group members have a voice, whether they have to be supported by ourselves and each other, sometimes in their own language if it's easier, and then another member will translate. This is all giving us a voice. We've given many presentations at European Parliament and contributed to consultations for different projects all over Europe. And other areas of the organisation's work as recognised experts by experience, because that's what we become. We also contribute to many external organisations as peer researchers and attend international events and give media interviews, not just in our own countries, but internationally. We show, or try to show, that there is a life after diagnosis and try to inspire others to come out, stand up and speak to change the lives of others, especially for those who do not communicate anymore. This collaboration really works and needs to be replicated, I think, across other patient groups to utilise the experience, the expertise. And then the group provides peer support for each other, which I think is invaluable. All this happens because we are enabled and not disabled. We are seen as people first. Our diagnosis does not define or label who we are. And all Alzheimer's Europe staff and the members treat us as full equals, and why not? The best thing of all, though, is when you see a member who previously had maybe lost their confidence, their value, and even lost themselves sometimes after diagnosis, mainly from the stigma that's out there, the lack of understanding, but then they begin to flourish and start to live again. And I think that's what's giving people a voice with Alzheimer's.
Thank you very much, Chris. Very powerful. Thank you. So let's move on then to Freek Spinnewine from FIANSA, which is the European network representing homeless people. Freek is also, very importantly, the president of the European Public Health Alliance. So how can we better channel the voice of homeless people with chronic conditions, and what are the key barriers? Freek, I know you've been working in this field for very, very many years, so share with us some of your thoughts and ideas.
Thank you, Nicola. You're trying to also make me feel old by referring to the many years. But it's true.
Fair.
Yeah, it's true. Good morning, everybody. Well, there is barriers. That's for sure. Can I just, for those, because I guess that homelessness is not an issue that you're very familiar with, just tell you how many people are affected by the problem. We estimate that on any given day in the European Union area, there's about 700,000 people that are or living on the street or living in a shelter, an emergency accommodation. And almost all these people are sick. They have health problems. And multimorbidity is something that affects homeless people to a very large extent. And people that move between shelter and the street for long times have a very low average age of death. It's usually under 50 years old. That's 30 years less than the population. So that just to say that homelessness is a health issue. But I have, after being invited to this panel, for which I'm very grateful, I started thinking, why are homelessness or homeless people or the homeless sector not part of this patient movement? And I see four problems that we have to overcome, and that the patient movement has to overcome. And sorry to sound a little bit crude, I'm not an expert in this area, but I still want to say what I think, and then it can probably stimulate discussion afterwards. I think, first of all, it's because homelessness is an undeserving cause. People don't like to work on the issue of homelessness. And actually, the link to diseases doesn't make it a more deserving cause, because the focus is on the least deserving diseases, if that makes sense. It's the infectious diseases like tuberculosis, hepatitis, these kind of things, which can be considered a health threat. So I think we'll have to try to overcome this kind of undeserving nature of the homeless problem. The other thing is that homeless people are not organized. You say that we represent homeless people, but actually we represent services working with homeless people. It's a flaw. Mm-hmm. And I hear that the patient movement has a lot of experience with empowerment. I think we could do with that. Because homeless people are not organized and not organized as patient organization as such. I think the third reason is that you cannot link homelessness with one specific disease. You cannot ask homeless people, what is your primary disease? Multimorbidity, like we said, is a real issue. And probably you could say that homelessness is not so easily related to diseases anyway. There is other issues that are probably more important and less prominent in the patient movement. It's affordability, for instance, but in a very different way. We don't think about the basics of affordability. We take for granted that part of the health system is universal, but actually for homeless people, even that universal health system is not accessible. Access in general is a big issue, also in a very basic way, like the out-of-pocket payments, which can be very small to see a primary healthcare professional, might be unsurmountable obstacles for homeless people. So prevention is a big issue, but maybe in a slightly different way. You know what is the best medicine for sick homeless people? It's housing. Housing is the best prevention for the illnesses they have. And so I think that what we can bring is a slightly different perspective on health that is probably not picked up by the patient movement as it should be, and it makes it difficult for the homeless sector to profile itself as an actor in the health sector. So I think that's what I wanted to say initially.
Thank you. Lots of challenges. Lots of food for thought. Let's move now to Tamas Berecki, who's the UPATI Director of Communications and a long-time member of the European AIDS Treatment Group. In our prep call, Tamas, we looked a little bit at some of the political tensions within a movement, and it would be interesting to hear what is your experience in the HIV community. We also looked briefly at the national context and why in 2019, discrimination and stigma still prevail in some national contexts, or many national contexts actually. Tamas, your thoughts?
Thank you, Nicola, and hello everyone. And it's not just in the national context. I think that what I've heard from these talks this morning and also yesterday, I think that the elephant in the room is stigma around illness. So that's what we probably need to address a little more and a little more clearly. And that's actually the experience that we from the HIV world can bring in. Because on the one hand, I'm a respectable grandfather, a researcher, social psychologist sitting here and talking smartly, but from another perspective, and for many other people, I'm a gay junkie with AIDS. So it is, we carry these labels that are very stigmatizing, and we need to confront this. Now, a case asked yesterday or complained that there's a lack of activism and there's a lack of direct action, that this has dissipated from the patient movement. But ladies and gentlemen, look around yourselves. We are the establishment now. And the establishment hardly ever makes or starts revolution. So we need to reflect on this. We need to reflect on how we can include those people who are marginalized, homeless people, or undocumented migrants, or refugees. And that's, again, an experience that the HIV movement can bring into, once again, into patient activism or patient advocacy, because we have always been working with these populations, because infectious diseases don't know borders. And But there's another point that I would like to highlight, which we also mentioned, and we also again learned from the HIV movement, or what's left of it, is that, yes, we all love each other here in this room, and it's all about solidarity and being together, and we want patient engagement. But what happens when we have to bid for the same pot of money? Suddenly, there's fierce competition across what we describe here as a unified patient movement. It is not there as soon as we buy into health being a zero-sum game. So remember this recent example when in the UK, the government pitched PrEP, like prevention of HIV, against breast cancer. So the government blatantly said, we can't have both. We can either have PrEP or we can have breast cancer prevention. And you guys figure it out. But that's not fair. Health is not a zero-sum game. So we have to stand up and say, and work together, rather than competing against each other across disease areas, across patient organizations, trying to fight for attention, trying to fight for resources. We have to actually walk the talk if we really want to work together, because citizenship is not only about rights, it's also about responsibilities. And I think that our responsibility as patient communities is to reach out to the underprivileged people who are left behind. And those are people who are invisible here as well. So those are people of color, those are sex workers, those are undocumented migrants or refugees, even with documents, they don't have an easy living either. So that's actually, I think that this is actually what we can still learn from the HIV movement or the hepatitis C movement. That you have to look at the margins, you have to look at the perimeter if you want to import or re-import activism into the patient movement.
Thank you, Thomas. So, delving deep into that concept of unity, I think is a very clear message. We'll now hear from Elina Smith from PICUM, the European platform representing undocumented migrants. We've worked closely over the years, particularly in the context of the Patient Access Partnership. What are the predominant health issues for undocumented migrants, and how does PICUM really try to ensure that their direct voice is heard in the work that you're doing?
Thank you so much, Nicola, and for the opportunity to speak today at your event. I wanted to follow up on Dr. de Messner's point that maybe the most compelling thing we can offer is the voice of the patients that we work with. So I wanted to share the story of a woman that we shared in a publication that we did a couple of years ago. This is a woman who lived in Denmark, and she was a cleaner for many different households, and she became pregnant. But because she was undocumented, under Danish law, she had no right to access any form of care, including prenatal care. And so she didn't go to see a health professional for the duration of her pregnancy. She continued to work until the day when she had significant bleeding, and her friends insisted on taking her to the hospital. And so she delivered a baby girl who died. So very sad. And so she remained in the hospital to recover, and during that time, the hospital staff called the police to inform them that she was there and that she was undocumented, and she was arrested. So I think this story illustrates, I think in a very powerful way, really some of the systemic challenges confronting people who are undocumented. On the one hand, if you're an undocumented person in most parts of Europe, you have an extremely limited right to access any form of care, except for emergency care. So unless you're in an urgent situation, in most cases you have very limited right to access care, unless of course you can pay. But most undocumented people, that's not an option. So on the one hand, you have a very limited access to services as a matter of just the nature of the health system. And on the other hand, when you attempt to access services, you face a constant risk that this could jeopardize your entire situation, in the sense of exposing you to the possibility of being deported and uprooting you from your life. And I think for many people, when we speak about undocumented migrants, we don't think about people who are rooted in our communities. Many undocumented people are rooted. They have families, they work in our homes as domestic workers, they look after our children, they are gardeners, they are building our homes. And so this is a constant threat that they face. And so why is this the case? Why do we have people in our communities who are excluded from our services, including healthcare? We often hear the same types of arguments from policymakers. Well, we can't allow them to access care because that will draw more of them. We can't allow them to access care because then they'll never leave. We can't allow them to access care because then they'll overrun our system and drive it into the ground. They'll abuse the services, when there's no evidence at all that this is the case. And so we see that the reality then is that these people confront significant barriers in accessing services. And so a big part of PICUM's work is precisely, as we've already been hearing, is demonstrating how the issues that these people confront, people who are undocumented, our neighbors, people in our communities, these are not special issues or niche issues. These are matters that concern the equity, the inclusiveness, and the resilience of our health systems. And there are real consequences in terms of public health. There are real consequences in terms of individuals' lives. And so we try to bring these issues then, working with diverse partners, including patient organizations, including health professional associations. We work with many. We work with health professionals at the local level and try to show that this is an issue for them. And many of them are starting to understand how this is an issue for them and that this is an issue that we all need to care about because it concerns our health systems and how well they are working for everyone.
Thank you. Very clear messages, also illuminated by that tragic story in Denmark. Thank you very much, Alina. Alain, you're representing Eurodis today, Alain Cornet. We talked also in our prep call a little bit about the particular challenges for patients with very rare diseases, ultra-rare diseases. Share with us some of your thoughts. I know you've also been very much involved in the lupus movement. What's your ideas around inclusion and the real voice of these people?
Right, yes, thank you. Hello, everyone. So I'm here today to represent actually people which officially have access. They have access to all the care systems for the majority of them, but they live with a rare or a very rare disease. So they have access to a system that has no solution for them. And that is another of the key issues that we face. So if you look in Europe, there are about 6,000 different rare diseases. And lupus is one of the rare diseases, but it's a frequent rare disease. And so from the 6,500 of these diseases represent 98% of the population with a rare disease. And then the 2% of the population, they live with 5,500 different diseases. Sometimes you have 10, 15 patients. How are you heard, even when you shout very loud, when you're just 15 or 100 around Europe? Now, a couple of years ago, came a big initiative from the European Union, which is to create a reference network to say, oh, that rare disease, maybe there are only 3 or 4 experts in that disease. So how can we link all the countries in Europe so that we can offer a solution? We can offer an understanding of a disease and of maybe the beginning of a plan. How can we group there? And there, Eurodis came and said, we need patients in there. And that was a lot of work to get patients because most of these patients are unknown. They're very small groups in a few countries. So the first thing was to make sure to give access to people which are living with a rare disease or an ultra-rare disease is the big need to help the small. You need to get together, but you also need the bigger organizations helping and supporting so that the smaller ones have access. Then the ERN, the European Reference Network, got created. There are 24 of them. They specialize on rare diseases, and they group from 5 or 6 up to 50 or 100 rare diseases with doctors of the same specialty. And there we started working together, and solidarity, which is something I've heard a couple of times, is what started to play. So in the reference network, the bigger ones, the ones which have more resources, and the lupus group is one of them, help the smaller ones. For one of the rare diseases in our reference network, we could only find one patient representative that actually doesn't speak English. How do we help that person to get a voice on the table? So you need to bring people in the room by having them there. Then you need solidarity in the room to help those with a smaller voice be heard and bring their problematics. So we have pairing of people that have experience with people that have no experience. So gradually we bring them to learn more. We have worked together on guidelines. Yes, guidelines is not the solution to everything. You need the guidelines to address the real need. Well, how do we help people with rare disease establish what their real need is? Maybe there is no cure, but this is what I'd like to achieve. And sometimes it's being able to walk 5 or 10 meters independently. How do we help that? And it's all these differences. How do we help that? And that happens in the reference networks. We are now working on designing patient pathways. How do we help people with very rare disease design their pathways? And the support of the bigger organizations there, we bring them to our training. We help them write the things in the correct way so that it's going to be understood, so that they can make their point through. And then the third point, which is important once you're in the room, is you really need to be able to make a difference. And to make a difference, you need to grow skills. Now, when we have large organizations, you can find skilled people. Actually, those skilled people are very often not representing the full population. The majority of patient advocates speak English, have university education, live relatively good, correct. They have enough money to be able to pay for some of the residual expenses that are there. And how many of the people are actually in the minorities and don't have that full voice? We need to make sure we include them when we go there, but we also need to help them grow their skills. There's a wonderful program with UPATI. And how do we bring more people to do the first steps that maybe 5 years from now will enable them to join UPATI, because they can't jump from now to the golden standard, okay? And so all these things are where I think you can make a difference. Because if you think at your programs when you design something and you think at, oh, can I also make this available for people which are having another disease than the one I'm working with, but are close, and maybe that program can be offered. Can we invite some of those people to your congresses? We are inviting now to the lupus convention next week a person which doesn't have lupus, but is a connected disease. She's got no organization. She can come and learn from what we do, and then reapply, we can support it. And I think solidarity is the #1 rule. We need our patient organization to think at diversity proactively, at thinking indeed at the migrants, indeed at the people which are homeless, indeed at the people from less favored social conditions, but also at the people with a rare disease for which there is probably no payout to find a cure, for which there is no voice to even go and knock at the door to say, help me. So that's the voice of the people with rare disease.
Thank you very much. So once again, going back to solidarity, but also that transversality across different patient groups to shared learning, capacity building, and so on. I'd now like to open up the floor for any comments or reflections, ideas, thoughts. We don't have a huge amount of time, so please, go ahead, don't hesitate. Lady at the front here, please. Can you introduce yourself very briefly, and if you can make the question quite brief, that would be great. Thanks.
Good morning, everyone. My name is Petronella Jurissen. I'm from the European Coalition Living with Obesity. I recognize so much. I recognize the stigma. And while we're not a rare disease, we don't have treatment either. And what small treatment there is often doesn't get paid for by the health insurance. So, yes. And then we're very young as a group. We incorporated in April, so I recognize so much.
Mm-hmm. And you don't have a specific question, you're simply...
I have a question.
Right.
How do we get more people involved, more patients involved, because of the stigma and because many people still don't think of obesity as a disease, but something that is just temporary, especially people who have a mild version. Mm-hmm. They think, well, I go on a diet and it's gone. How do we get them involved?
Okay, I'd like to actually invite Thomas to respond to this, because I know you've done a lot of work in growing patient organizations over the years.
So I think that you cannot spare the legwork. So you have to really go back to the roots and go and talk to people. Social media helps a lot. I mean, there's a lot of nonsense out there on social media, but it really does help a lot if you have a well thought through strategy and you reach out to people actively and you build a community first. That's how it starts. And then when you have a community, then you must also build evidence for your cause. However callous, however striking it seems, you will have to argue for your most basic rights. So you will always be able to back up your claims with hard evidence, but it's doable. So that's what we call evidence-based advocacy. So first you must build a community, and then you must build an evidence base, and then that will also give you the right amount of skills and empowerment, self-empowerment, which is not coming from the outside, to stand up for your claims and for your asks. But it's a process, and then of course you you will rightfully ask me, okay, but who should fund this process? And that's where it becomes tricky. And that's where I say that instead of competing and pitching it out against each other, we have to do this together. We have to maybe stigma is the point that brings us together. Maybe it's something else. I don't know at this time. But we have to find the common ground that will, because just saying that patient engagement is something that we all want, fine. But what is it that actually keeps us together? What is that common ask that will keep us together? And maybe that's stigma and discrimination, maybe not. But that would be, for me, the first point to clarify, so that we don't compete against each other, and I don't have to come and talk to you in a year from now and saying that it's either obesity or HIV prevention, because that really should be avoided.
Thank you very much, Thomas. Any other comments, questions? No, sorry, I have to give the opportunity to other people. Okay. Please.
Thank you. I was impressed by the presentation given by Professor de Maasen there this morning, but I think it's very important for health policy for a government to invest in patient organizations, because if we do not do it, we have to ask membership to people. We have to ask sponsoring for commercial companies, and it means we cannot reach those people who don't give 20 or 25 euro to a patient organization because they have other priorities. And we are building right now a European network of patient organizations for sleep apnea. We have a huge problem to address people in other language who cannot speak English. So it's so crucial to do those kind of investment. And we see that the government, especially in Belgium, especially in Flanders, do not invest in this kind of needs we do have as a patient organization.
Thank you. I'm not going to open that up for any comment. I think you've made a very, very important point, and I think we can all relate to that from the patient community. Thank you very much. One more question, I think. Please.
Good morning, everyone. Yanis Natsis, advocating for better and affordable medicines with the European Public Health Alliance and an EMA Management Board member, along with Marco Greco. Tamas, thank you so much for the inspiring talk. Thank you for provoking us, and I really appreciate your references to the real-life examples that we see, for instance, PrEP against breast cancer. Recently in Belgium, we had even on public news stations, patients competing with other patients over the costly medicines. I think also Professor Jan de Maasen referred to it in his speech. I hear your calls for moving towards more activism. So I would like you, and you referred to the AIDS movement, which was a turning point. So what can we learn and how can we respond to these challenges today? Have we become too comfortable in our relationships, for instance, with the pharmaceutical companies, specifically for the patient groups, but not only? So what would you say in order to address this real-life challenge? Thank you.
So this is closely related to what you said about funding from government, and so that patient organizations are not exposed to obtaining funding only from commercial organizations, because that also has the consequence that patient organizations increasingly have to buy into market-oriented commercial corporate structures, which is against the very logic of the patient movement, which is about solidarity. It is about altruism. It is about sharing resources rather than accumulating resources. So that goes against the market logic. So I think that that's the first step. We have to move away from the market logic and say, what is it that we really want? We want solidarity, but you have to act on solidarity. It will not happen just because you say that you want it to happen, but we have to sit together around one table. EPF is a brilliant forum for that, and there are others, but I mean, we're here now, so why not sit together around the table and see what keeps us together? What is it that we want? Is it affordability? Maybe. I cannot tell you this. But that's actually what we learned from the HIV movement, that we cannot afford to say that there are substance users and there are men having sex with men and there are sex workers and they are all separate people, migrants from Africa, and they are all separate groups. We're all in this, we all live with the same virus. So that's the common point.
Thank you, Thomas. Time, unfortunately, is not on our side, and we're running out of time now, but I think we have enough to actually be able to invite all of our panelists and Jan to just leave us in one sentence, one thought on how we could really move the needle so that people come out of this room with some sense of inspiration. EPF and our stakeholders and allies have some sense of direction. And if I could just kick off with you, Jan, once again, and work through the panel. One sentence, essentially, because, as I say, our Masters of Ceremonies will kill me afterwards. Go ahead.
One thing that I'm waiting for is who is going to take care of mental health patients. We did not address it. I think it's a major issue. And taking that as an example, I think that it is so important that independent patient organizations can link up with critical academics and with civil society organizations. If you see, when it comes to the opioid epidemic in the United States, how civil society and patients organizations really went into court in order to look at the upstream causes and to go into procedures that finally led to the fact that the upstream causes are addressed and people that were responsible were also take the consequences of what they were doing. I think that it's so important that we link that up. And last point, don't forget the global perspective. It is impossible to have health in Europe if we don't have health in other continents.
Thank you, Jan. A very long sentence, but excellent. Thank you very much. Alain.
Well, I'm going to take it probably from the other angle with much more humility, but somehow I feel like if we want to make a difference, it has to start with ourselves. And I think the one thing that can make a difference tomorrow is if we all go and note down, here is the small step that I can do to improve the situation of maybe an undocumented migrant next to me, maybe of the rare disease patients, maybe, but what can I concretely change in my organization, in my own behavior tomorrow, and write it down and read it back 30 days from now and do it. That is what's going to make, I think, a difference. And then we'll rely on EPF and the big organizations to go and carry the voice for the structural change that's going to come after that, based on our individual commitment to a change.
Thank you, Alain. Alina.
I wanted to pick up on the competition point, because oftentimes limiting access for undocumented migrants is that is necessary to protect everybody else's ability to access the healthcare system. And I think it's really important to push back on the argument, pitting people against each other, that we need to exclude these ones to preserve the system for these ones. And really in our argumentation on universal healthcare, everyone is better off when everyone can access care. And just very quickly, my second sentence, being proactive. So there are countries in Europe that have a long history providing access to healthcare for undocumented migrants. Belgium is one, France is another. In France, for example, there are attacks right now on their system of healthcare for undocumented migrants. And EPF contacted me to say, I heard about this, what can we do? Being proactive is so important, and it means a lot that the patient organizations saw this as their issue as well, not just about undocumented migrants, but really about protecting and preserving the health system overall.
Thank you.
Mine is very simple. It's more cooperation, less competition.
Thank you. You did speak a little earlier, though. Thanks.
In the same sense, this is my first participation at an EPF conference. Shame on me, but I hope that it can be the basis for future cooperation. Maybe EPF should think of opening up to organizations that are not profiled as patient organizations, but are willing to reprofile themselves partly as patient organizations like mine. So maybe we should look into membership of EPF.
Thank you, Freek. Last but not least, Chris.
Yeah, thank you. Dementia is all around us, and that's my actual passion at the moment, because I'm living with dementia. So And dementia never really moves on its own. There's always accompanied by other comorbidities. So let's all, instead of nothing about us without us, it has to be nothing about us without all of us. Let's all be together, no matter what illness we have, no matter what's affecting us, and stand together.
Thank you. That's a very powerful last message. Nothing about us without all of us. I feel like we've just started the conversation and we're at the end of this panel session. I hope hopefully we've actually stimulated some really quite profound reflections on how we could actually move forward. And I know there's a lot of people listening to this conversation very, very carefully. I'd like to thank Jan very much for his excellent keynote speech and the panelists for their very open, very honest remarks. Thank you very much. And I hand the floor back to our Master of Ceremonies. Thank you. Or Mistress of Ceremonies.
Thank you very much. And I'm very aware that I'm white and I'm from a certain economic class. And actually for the last year, I've been working really hard to reach my hand down to those who don't currently have a voice, because I think it's really important that we do that. As Chris said, we've all got to work together, and all of you have said. I'm here to tell you about the structure for the next 2 parallel sessions. So you have a coffee break now. But after the coffee break, you will split into different rooms. On the back of your lanyards, it says your room and what that parallel session is. Now, you will also have a parallel session after lunch. Stay in the same room, okay? Don't go wandering about. And also, we don't have enough room for people to start switching into different sessions. So if you could stick to what is on your lanyard, please, that would be very, very helpful. So you have a coffee break now at 11:15, and you come back, to your parallel session at 11:15, and then you'll have lunch, and your parallel session will continue then at 2:30. So if we could please stick to timings, it's very, very tight, and I hope you enjoy your coffee break and your parallel sessions. You are free to go.
Okay, ladies and gentlemen, welcome to the afternoon plenary session. It's fantastic to hear you so much enjoying the discussions of the coffee break. You still continue them. Keep up the good spirit of conversation. So, I hope you enjoyed the parallel sessions. Just a quick question. Who has been involved in the parallel session measuring the impact of patient involvement? Who was there, right? Can we ask then session moderator Nicola, where are you, Nicola? Yes. Can you just say one sentence about this parallel session? And I also will ask the session moderators for the other sessions just to say one sentence how it went, how they feel after this discussion. Please.
If it's okay for you, I'd like to give the floor to my colleague Vale, who actually chaired the session.
Valentina, please. Yes.
Okay, thank you. So, in one sentence, that's hard because we had a lot of thoughts and a lot of ideas, and we really squeezed the brains of our participants, I would say. I would say there's a lot of work ahead because the impact of measurement of impact of patient involvement, it's a quite not so new topic, but it's getting a trend now. And so this means that we only have to work more. Mm-hmm. So that's unfortunate for the EPF team.
Okay, thanks a lot. Thanks for your work, by the way, for both of you in this parallel session. Okay, so the next session was how the patient perspective can improve healthcare performance assessment. Who are the ones who were in this session, who participated in this session? Can you wave your hand? Okay, and Joseph Figueras is here among us. Maybe he's so worn out after this discussion, he's still, just coming in. Okay, no problem. Maybe he'll show up. Or anybody else who can say one sentence about this session, and anybody brave enough to come on the stage or grab a mic? Okay, they are still prepared. Okay, somebody with a nice sentence of wisdom. Okay, the third session, patients as partners in research, making co-production the new normal. So who are the colleagues who have been in this parallel session? Who are the ones? Perfect. And then do we have here somebody from, Matthew May, Matthew Booth, or Jacqueline Boers, or Karina Pittens? Anybody who is ready to say a sentence?
Wants to talk?
There you go. All right, thank you.
Okay, I'm the only one here, apparently. I know Match's run to get a flight, and the other two are just tidying up things. We had a very good discussion. Main takeaway, really, from our session is we spent the morning sharing some experiences about what successes have been seen across changing the way that we involve patients, how we can incentivize or perhaps punish and give consequences if people don't give patient engagement a true try. And using these experiences, we actually pulled out some building blocks and spent the afternoon session as a co-creation session split into 6 topics that are currently topics that are undergoing discussion within the likes of Paradigm, within the likes of patient-focused medicines development, within the likes of UPATI. Because one of the things we were fearing is that there are lots of frameworks in development. We actually had a quick show of hands about how many frameworks we think are out there. The maximum someone said was 20. The literature review that we'd done previously said 61. Okay. And our big fear there is, if there are 61 frameworks existing currently in development going forward, how do we ensure that there are commonalities between all of those frameworks? So what we spent our session doing was pulling out what we think should be in every framework going forward, irrespective of whether it's focusing on medicines research and development, early research, publication. Doesn't matter what area, if we're talking patient engagement, there has to be commonalities so that we don't keep duplicating and working in parallel.
Thank you. It's a very nice summary. Thanks a lot. Okay, next one is designing better healthcare services with patients. I know Miklos Socska is gone. He's flying to Riga. But there was Lyudmil, maybe Lyudmil if he's around. Is he around? He's still wrapping up, or Jelka, or Dusan, Dine, Jan. Any of you here? Yes, there you go. Please. Dusan.
I have to say something. the bosses are missing. So I'll try to sum up. Very, very inspiring practices have been shown up from the Spanish, from the Danish, and maybe Slovenian part. The patient involvements were shown in reality already going on. So whoever was not there, I encourage them to see what, the summaries on the line when they are up on EPF site. Thank you.
Okay, thanks a lot, thanks. Okay, and then next one is how to ensure digital health brings real-life benefits for patients. Who are the participants? Can we see them in this discussion? Okay, quite a few. And then who is taking over? Diane Whitehouse, for example. Is she here with us? There you go, there she is, all right.
So the benefit of a session about digital health is that we did indeed use digital, and we did lots of nice polling and surveying and answering questions. More than that, people were very willing to share and to be honest and to be transparent about their situation. So there was some very, at times, very moving interventions. 4 excellent speakers. A European Patients Forum youth group that did some superb amateur dramatics. And I think last but not least, lots of brainstorming. And I did see yellow or pink stickies up on the screen earlier. Costas, to whom we should say rah, 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 and thank you very much indeed, will be working with us all to develop a report, and it'll come back and you'll all be able to see in detail what we talked about. Thank you, everybody. Thank you.
Sounds great, really great. Great summary. Thanks a lot. Okay. And then the last one was patient safety. How can patients and families help improve it? Participants who are participating in this session. Perfect. So, and it's Tamsin Rose, I think, is she around? No, she's left. Okay. Who else is taking over? Mark Molloy, who is ready to talk.
I could maybe do it. I'm
Please,
Kaiser from EPF, just because I was there with Tamsin and she's gone. But we had a really, really good session with maybe, few but high quality participants and some fantastic speeches. A presentation from Roshan and Mark Molloy set the scene really well, telling the patient experience of how the relationship between patients, families, and healthcare providers is affected by when something goes wrong in the healthcare environment and it's not dealt with as well as it should be. And then we started discussing about the enablers and blockages of how to create an environment where patients and families and everyone, also the health professionals, feel safe and able to be open and catch errors and things that are at risk of going wrong. And they used the analogy of that. You may have seen those who have been on the London Tube, see it, say it, sorted. So we should aim for somewhere where if we see something, we shouldn't be afraid of saying it and then being able to trust that it will be sorted. Now the how is could be a bit overwhelming. We talked about culture change, and culture is a bit overwhelming, but it gave us some good ideas of where to start, because in a way, how do you eat an elephant? You have to break it into small pieces and eat it piece by piece. So now we'll start at EPF looking at what those pieces could be and find the concrete hows, maybe taking inspiration from different contexts where things have happened in a positive way. So it's like a roadmap for us.
Good. How to eat an elephant? Very important question. Okay, thanks a lot. Okay, thank you. Now following a wrap-up of the parallel sessions, now we are proud to welcome Mark Butene, Chief Executive Officer of the National Health Council from the United States, for our final keynote of the day. Now some nice things about you. As I promised before when we discussed a little bit, Mark has been a leading voice for greater patient involvement at every stage of the healthcare continuum
And in his keynote presentation, he will focus on the role of culture and leadership in ensuring that the patient perspective can effectively be brought into health policy and practice, with the voice of the patient at the heart of the process. Okay, so Mark, you're very much welcome. Please come on stage and make your speech.
So how are you all feeling? Good. Yeah, you have a very energetic crowd. I want to start off by thanking EPF and thanking all of you. I know I'm the last person you have to listen to today. So I'm going to spend a few minutes, and I'm just looking for the clicker, which we will find in a few minutes. Anyway, I'm going to start by describing a few things, and I want to talk to you about culture change. And I love the comment about eating the elephant. That's a big meal. Are you guys hungry? I want to start by simply saying that I'm obviously from the United States. I'm not from Europe. I actually grew up in a very rural part of the United States. In fact, where I grew up, most people didn't have electricity or running water. We actually carried the water in from a lake into the house, and it served our purposes for drinking water and for cleaning, for cooking. Thank you. And it was a beautiful place to grow up. It was up in the mountains. We had all kinds of wild animals. I even remember picking blueberries as a child and putting them into my pail. And there was a dog eating those blueberries, and I slapped the dog and turned around, and it was a brown bear. So I let him have the berries. And I decided I needed to get out of this place. There was really nothing going on. It was beautiful. So at 13, I left home. And I wound up traveling the world. I lived abroad for about a decade, ended up living in Europe for much of that time, and in Asia. Actually got a British law degree and international politics degree. And I was actually really, really excited. I'd been offered a job here in Brussels, the European communities, and I was so excited. This was my dream job. But over a period of just a few months, one by one, I started to get communications from my family. Every person in my family was diagnosed with one or more chronic diseases. They range from cancer, heart disease, neurologic, autoimmune, rare, and HIV. So I decided change of plans. I moved back to the United States, started practicing in law in Boston, south of where I grew up, and I started volunteering for a number of patient organizations that represented the people with the diseases that my family members had. And I started helping my family get to their doctor's appointments, enter clinical trials, trying to get the care that they needed. And I have to tell you, I was stunned at how difficult it was to have their voices heard. One by one, they were patted on the head and said, "This is what you need, go home." It was really, really discouraging. And as a result, my law firm lent me to one of the patient organizations. And I was supposed to be there for a year. And during that year, one by one, my family members started to die. About half of them died because there were no effective treatments for their condition. And then the rest of them died, even though there were highly effective treatments for their conditions. We couldn't get them to them in the right time, or there were accidents. It was incredibly frustrating as somebody who was connected to the healthcare system at this point, trying to help so many of my family members navigate. So I decided not to go back to the law firm. I ended up staying in the patient community, and I've been working with them for more than 25 years. I currently work as the CEO of the National Health Council, which is an organization that was created by patient groups for patient groups 99 years ago. And you see the logos of many of those organizations in membership up here on the screen. We work only on systemic issues, so our focus is driving meaningful access and affordable access to high-value healthcare and driving innovation, not just in the development of new treatments and new diagnostics and devices, but also innovation in how we think about healthcare. It's incredibly important, and in the United States, incredibly challenging. But there are a number of lessons we've learned that I think are issues that you are dealing with, and what I have found so rewarding from this meeting over the last day and a half, so much opportunity for us to share with each other. Starting a couple of years ago, I began meeting with the CEOs of the patient groups and their board members and their volunteers. I did these listening sessions, and I asked one question. I asked, what keeps you up at night? What is your most difficult challenge? And overwhelmingly, over and over again, I heard the same thing. I don't have affordable access to care. And in the United States, starting several decades ago, we've required that when you get care, you have to pay a fee. It was originally a concept of you had to have skin in the game, which I absolutely hate that expression. But it was really designed to help promote the use of high-valued care and reduce low-valued care. But it has evolved in the last 15 years to a point where it is really a mechanism to shift the cost of health to people with chronic conditions. If you are in the United States and you are of lower middle class, I want to emphasize that, lower middle class, and you have a family member with a high-cost chronic condition, you can expect to pay approximately 20 or 22% of your annual income to get your first prescription, to see your first specialist. What that means is many people with chronic conditions either have to make a choice between housing, food, or medication. And we're seeing people not get the care that they need. It's a huge, huge challenge in the United States. And it's leaving people with chronic conditions feeling overwhelmed and unable to get what they need from health. I think we have a huge opportunity to start to think differently. And we've heard a lot of folks talk about cultural change. And I can tell you, changing culture is probably the hardest thing you can do in an organization, in a country, in a society. It is not easy. And do not be mistaken. And I don't care if you live in a socialized system or not, health is big, big business. In the United States, it's approaching 20% of our economy. And there are many, many people who make their living in the health sector. And we want them to. But when it comes time to make changes, everybody points at everybody else and says, these changes would make sense, you change, but I can't change. It's not going to work for me. The entrenchment in culture is very difficult. And ordinarily, I would say to anybody who is going to try and change culture, think about doing something else. It's too big. It's too difficult. And yet, I've heard over the last day and a half, all of you want to change culture around health. Am I right? Oh, come on, more energy than that, guys. Am I right? Not going to be easy. And again, normally I would tell you don't do it. But I'm going to say this. I think we can actually impact culture. And I think there are a number of things happening in the environment that make this viable. First, there's an absolute explosion of people with chronic conditions. When I started at the National Health Council, 30% of Americans had one or more chronic conditions. 15 years later, 60% of Americans have one or more chronic conditions. 30% of children. And that is not a US phenomenon. That is a global phenomenon. We're seeing people live longer, and we're seeing more and more people with chronic conditions. And it's a real challenge because we are invisible. Think about that. As people, we don't understand the magnitude of the numbers of people living with chronic conditions. We are completely invisible. We think that you can pick out people with chronic conditions. Oh, it's the person without hair because they're taking chemotherapy. We largely can't tell. When you look at me, do you realize that I have survived cancer 3 times? Do you realize that my brow, my cheekbone, my jaw, my chin were surgically removed and put back? Do you realize that 6 months ago, I was diagnosed with colitis, an extreme form of colitis, and in 4 weeks, I lost 27 pounds? We don't see each other. And our society says, don't talk about it. How often do we talk about how we're feeling? Let me ask you, try this experiment. When you go home and you see your neighbor, and your neighbor says, hey, how you doing? Tell him. I'm starving all the time. And every time I eat, I have excruciating pain in my stomach. And then I have uncontrollable diarrhea. How are you? We're not conditioned to talk about this, and we don't see it, even amongst our own community. And I think we need to start thinking about how we shift that. It's time for us to come out of our closet and have a conversation. Because at the end of the day, the magnitude of people with chronic conditions are driving healthcare costs. They're driving policy in every single country around the world. In the United States, 30% of the population drives 80 to 90% of all healthcare costs. 5% of the population drives 50% of the cost. We are the drivers of cost, and that is creating change in our health systems. And we need to be at the table as we think about how we shift that. It gives incredible opportunity for change. So many of us represent organizations that actually have in our mission a mandate to find a cure. And I can tell you, when I started out in advocacy, I thought none of these complex chronic conditions were ever going to have cures. And we're now talking about therapies that you'll take once and you'll be cured. That's exciting. But it raises a lot of questions. If you can take a treatment and be cured and have 20 years or 30 years or 50 years of life where you are healthy, what is the value of that? It's creating incredible pressure on how we value health, how we value specific treatments, specific interventions. And oh, by the way, how are we going to pay for that? Everything in our system is predicated on, I'm going to take this treatment for the rest of my life. What happens when I only have to pay for it once? What is the value of that? How do we encourage future innovation? But how do we pay for that in the present? It's forcing us to think long-term in health. That is a very, very different perspective. We always think on the calendar year. That's how our governments are set up. That's how our insurance and payment programs are set up. How many of you experience your disease on a calendar basis? For me, it just keeps going, doesn't stop. It is challenging what we think of in health, and it's challenging all the ingrained systems. And most importantly, this concept of high value is dramatically displacing vested interests. Think about that for a moment. If I can take a shot once and never have to deal with colitis, never have to deal with the 2 medications I'm dealing with, never have to see that specialist, never end up in the emergency room, never be hospitalized, a whole bunch of people are not getting future payment. It's displacing current vested interests. And that is challenging our system and creates incredible opportunity for change. You know, there are more than 100 companies based here in Europe that have thousands of data points on each and every one of you. Think about that. They know how you consume news. They know what you like for entertainment. They know what you buy for food. They know if you have a gym membership. They know if you use your gym membership. And they're using that information to influence you, to get you to buy things, to get you to watch things. We still talk about data as if it was clinical trial data. And yet, all around us, data has been collected. The biggest disruption in health is not going to come from the health sector. I would submit to you it's going to come from retail. Think about that. Think of retailers like Amazon and CVS and other large retailers that are now buying delivery systems, insurance companies. Why do you think they're doing that? The reason they're doing that is they want to combine the data they have on you and your consumer behaviors with health data. And they're going to run that through algorithms. And their hope is that they can identify future outcomes that you will have and influence your behaviors. And we're already seeing models in Europe and the US where this data is being used. Again, not clinical data, but data about you and what you're doing in the environment, non-health data. And they're able to predict things about you and deliver interventions. And what we're seeing is an opportunity to move from population health and start to look at the individual and deliver care that's tailored to them. And what we're finding is we get much better outcomes at much lower costs. And it's debunking one of the greatest myths in health, and that is that patients want everything. Many in the healthcare sector are afraid to speak to us because they're afraid patients are going to tell them they need everything. And the reality is, and you all know this, we don't want everything, we want what works for us. It's very, very different. But it's challenging our old notions. With these trends that are undercutting some of the traditional foundations of health, we actually have an opportunity to change culture. And it really requires three elements. We have to explain what our vision is, we have to normalize behavior, and we have to punish outliers. And Matthew actually said this when he spoke earlier. It's a really interesting balance, but I can tell you we in the patient community have gotten pretty good at telling our stories. We need to get better. We need to explain our stories in the context of why personalized health matters. It's more than just saying that we have a chronic condition and how it affects us. It's how the care can help us live the life and achieve the outcomes that matter to us, and why that is important to society, how it can help save costs, make us more productive. Huge opportunities. And for those of you who work in policy advocacy, we need to start to think more critically about how we align the incentives and remove barriers. If there's nothing that I have learned from living in Washington, is if you want people to change behaviors, change their incentives, take their barriers away. And we need to think critically about all the different players in the ecosystem. We heard from primary care physicians yesterday who you start to feel like there's almost a tension between the patient community and our doctors. And yet they're our closest allies in the healthcare system. But they are under siege too. They're forced to see lots of people. They don't have the time to develop a relationship with individuals, to do the shared decision making. We need to align the incentives so that they can. Huge opportunities. And perhaps most important is this issue of coercion. So often we start with how do we get charismatic leaders out there and tell the story, create the influence. And then we pull back. We have to go further. We have to create the infrastructure, and then we have to put the intimidation in place. Because if you don't, and there's lots of research on this, you can go all the way to the second phase of this. If you don't have the coercion in place, it reverts back to the status quo very, very quickly. So if I have a call to action for this audience, it's this. Partner with your umbrella organizations, with EPF, with organizations like the National Health Council, PFMD, Eurotas. There are lots of them around. Partner with them and start to develop a strategy. The environment is on our side. You're seeing huge changes in the health sector, and health 5 years from now is going to look very different. We have an opportunity to develop a strategy that shifts culture. And it starts with coming together and being more clear about what our vision is. It doesn't need to be complicated. All we need is personalized help that helps us to live our best life. We need to look at our countries, at Europe, the United States, and dissect the problems. We've all been great, and we've all been talking about how difficult it is. We have to do more than just generalizations. We need to get into the very, very specific problems and identify very specific solutions, and then identify who can actually impact those solutions. You start to prioritize on what will have the greatest impact for your mission and what has the greatest feasibility. And you start to tick them off. And you do this as a community, and you share it with a group. And while no one organization here can take it on by themselves, if you can create a shared roadmap, we've done it in patient engagement and drug development, people will start to identify the part that they can do that no one else can do. And we can start to shift culture. We're actually in a place where this can happen. It's happening already. Our challenge and our opportunity is to accelerate it and to ensure that it is patient-centered and that we don't have any missteps along the way. We are perhaps the most important stakeholder in this. We are the least resourced, but we have more passion than anyone else. And the last point I'll share with you on culture change is this. Never forget this point. And it's this. We don't live for health. Let me repeat. We do not live for health. I don't live to take my medication. I don't live to see my doctor. I'm not looking forward to my next surgery or hospitalization. We live to be happy.
人为什么活着？为了思念，为了活下去，为了活更长，还是为了离开？
去骑摩托车吧！
5个台湾人，平均年龄81岁，1个重听，1个得了癌症。3个有心脏病，每一个都有退化性关节炎。6个月的准备，环岛13天。1139公里，从北到南，从黑夜到白天，只为了一个简单的理由。人为什么要活着？
Let me just say thank you to EPF, but most importantly, thank all of you for helping people with chronic conditions live their dreams, live their lives. Thank you.
Mark, you've left me reeling with that. Absolutely fantastic, inspirational talk. And you covered such large areas. And this focus on culture and being able to shift the culture. Lots of different aspects to it. And you were saying that you can sense it, you can feel it, that there's a sense that there's a movement. Is there any, if I gave you the magic wand, what would be your sort of first action then from what you've talked about that would help really accelerate that culture change?
The first thing I would say that we can do to accelerate that is to help help people understand that all of the people we work with in the healthcare system, all of them are very well-intended. They support us in many ways, and this is not at all a slight against them. But we live in a medical society that is paternalistic, and it makes assumptions about what we want. And those assumptions sometimes correlate with what is important to us, but in many cases, they miss the mark. And if we don't explain that in real terms, people won't understand it. And there's a great example I use a lot to really drive that point home, and it's in the Duchenne's muscular dystrophy space. Duchenne's is a horrible disease that attacks mostly boys. It's 100% deadly, attacks their nervous system. They lose the ability to move, even to breathe. And for a long time, you had folks looking to develop treatments that would extend their lives by 6 months. They borrowed from the oncology model. But when you spoke to the families and the children with that disease, what they said was, I don't want to live 6 months. At that point in my life, I'm worried I'm going to choke on my saliva while I'm sleeping and not be able to call out for help. What I want is the ability to grab my sleeve with my teeth, throw my hand on the table, type out a message to my friend. Point being, we make assumptions, and we generally focus in on survival, quality of life, sort of how we feel, function. The reality is those are the right buckets, but we have to engage people with those conditions, their family caregivers, to understand how they balance them. And we need to understand that health is a tactic, and that's important. Most of our surrogates think health is the strategy. They give you the strategy and say, do this and life will be fine. Well, no, it's a tactic amongst many others that help you to live your best life. We have to do a better job of helping people to understand that. We don't even communicate well about that within our own communities.
Yeah, and you bring that out so well in terms of what matters to patients, and being able to understand what matters to patients. Set that then against one of the quotes from an orthopedic surgeon that stuck in my mind. It was told to a friend of mine, a patient, after a hip operation, when he said, "My advice is to take my advice." And for me, that encapsulated actually every problem with the current culture around patient engagement, but also there was a kernel there of value. Mm-hmm. How do you feel you can not lose that kernel of value while trying to remodel what we need to have patient-centric care?
So I want to be clear. Sometimes we think of patient centricity, patient engagement as a black and white issue. We don't want to undermine the value we get from our healthcare professionals. They have a great deal of expertise. It's really, how do we have the conversation in context? And it requires us being able to articulate what our goals are, and then to have that conversation about what is the best strategy to meet it. You know, I have a dream in the health delivery systems, and it would be for 2 new measurements. Like a few people pointed out during the course of this conference that measurement is really important, and it absolutely is. But what if we had 2 measures? One, can I articulate the outcome that this person and their family wants? Process measure. Can I articulate that outcome that they desire? Number 1. Number 2, what is the strategy we put in place that was realistic, based on evidence-based medicine, that will help them most likely achieve that outcome? Those two things would really transform health. But we have a lot of work to do to get there. But when we get there, health is going to look very, very different.
Fantastic. I would like to selfishly contain all the questions, but I know there'll be questions out in the audience. So let me look out and see as a hand goes up. Comments or questions for Mark? I'm going to take right at the back.
Hi, thank you so much for your presentation. It was quite inspiring. I'm Alex, I'm also from the States, and I work at UCL Louvain. And you brought up a really interesting point, I'm just digging out my notebook here, about Amazon and all of the data that's being taken and used towards kind of moving forward with, okay, they're gonna start implementing interventions for our health. And my question is what we've seen with Facebook, use of data, and Google, how can we ensure that they use it responsibly, that we can trust them, and that we can move forward?
In the current environment, I would say you can't. And so I really appreciate that question. It's one of the issues I know we in the US, I hope you in Europe start thinking about. And that is, how do we use all the information that isn't necessarily health data, that is going to be used to draw insights that are going to impact our health outcomes? We have no real systems around that. And so how do we ensure that it's used appropriately? And be very careful. I think it has to be used for this purpose. I think it's a huge opportunity for us, but it's also a huge risk. And we need to think about how we manage that from a patient perspective. I think an element we need to consider, and I've heard people here say this, that we should own the data, patients should own the data. I actually don't agree with that. And the reason for that is the data is about us, but you know what? Other people have to create that data, they have to curate that data, they have to store the data. There's an expense associated with it. I don't think we can say we own it, but we can say we have rights in how it gets used. And I think we have to figure out what is the right basis. Because what fundamentally drives me nuts right now in the health ecosystem is data is a commodity. And people are monetizing that commodity about us. They're making money off it. We're not getting the money back. We have no control over it. I think data should not be the commodity. The commodity should be what you do with that data to benefit society and individual people. You ought to get paid for that, not just for having the data. And I think we need to think about how we turn that on its head. And I think there's opportunity there, because eventually you're going to see these rules that make the data flow more smoothly.
Again, looking out, see if I can see the hands as they go up. Albert, absolutely, at the front.
Thanks for this presentation. I really enjoyed it. So at the very beginning on the screen, you had all the organizations that basically coordinate. And I think this is the direction we also want to go forward, right? Maybe EPF or other organizations kind of getting into a network and stepping up together. So I think you can share some experiences, how you kind of keep developing this network. That I've seen from the logos that you're kind of in the middle of all these American organizations, NGOs. So can you recommend us a couple of things? You know, what you think is useful and beneficial?
A really, really good question. I will say that the level of impact we have in the US is very different than it was 2 decades ago. 2 decades ago, we did very little in public policy. And we needed to gain the trust of the organizations. We needed to provide a very high-value product for that trust. And perhaps most importantly, and I've heard people touch on it here during the conference, we can't compete with our members. And we have to be very careful about that. I don't compete with my members for resources. I don't compete with my members on disease-specific issues. But what I've tried to create is an organization they will come to accomplish systemic issues that they can't do alone. And you need to show people the value of that. Because the reality is, most of you who are representing patient organizations are there for a specific disease, right? See your head shaking? And that's critically important. And you have a great deal of expertise in your condition, and you are the expert in Europe for that, and you provide a great deal of value. EPF needs to have the best expertise on the systemic issues you want to lead. And when you have that, the organizations will come to that to get that value. But it takes practice. We began years ago on a specific issue, and I will tell you we had zero impact our first time. Our second time, we had some impact, but not great. And in fact, the large patient groups in our membership got credit for it. Really ticked me off. The third time, we had tremendous impact, and we saw the community coalesce. And now they see the value. So it was something that occurred over a number of years.
We just have just a minute or so. So if there's a last question there, looking out. We have just on the right-hand side at the front. And if you can just say who you are and where you're from, please.
Hi, I'm Christina from Cyprus, rare genetic diseases. You have touched the point about the gene therapy and where the healthcare system is going and how much it's costing. You see, for us, if you think that only 5% of the patients with rare genetic disease, they're hoping for a therapy or there is any medication. And they have a different quality of life because they are used to the unknown, and so we take everyday life differently. And holistically, we try to help this part. It's very hard for us when a gene therapy is out, and as you said, the system is trained to have a prescribed medication for the rest of your life, and it's very hard to understand that with one injection, you can go and correct the mutation, and hopefully, then you're gonna live a more healthy life, quote unquote. So yes, it's very hard to change the culture, and on the same hand, to get the health, to find the way of really have access to this kind of innovation. You know, accessing it's not one country's job, it's the whole healthcare system. And I think European Union should really allocate funds for that, and not to be a burden of one country. It has to be something that it will be accessible to anyone who needs it.
You raised a lot of really, really important issues, and I will say I get concerned in the United States. We're grappling with that issue, and we have a whole bunch of policies being floated to address access cost, some of which make sense, many of which don't. We have a president that is criticizing the industry, claiming that the US is funding innovation. And I think we have to stop thinking about that country by country. It's a global ecosystem. And I will say, we have rare diseases in membership. And as we're beginning to get treatments, and we're still in the very early stages, and I don't want to create an inflated expectation, but it used to be, I heard from the parents of children with rare disease, that the worst thing in life was having a child and finding out they had a rare disease, especially a deadly rare disease. And now what I hear them say is, the worst thing is having a child with a rare, deadly disease and having a medication that I can't get access to. We need to think a little bit differently. And I also will say that while we have issues with drug pricing, and we are addressing them in the US, we believe wholeheartedly that we have to really push innovation. We're at a critical point, and these inflection points come about every 15 years, where there's amazing innovation. And it's very expensive, and the expense comes down. You know, we in the United States in the last few months developed the first treatment for a child with a rare disease specifically for that one child. You know, it's evolving, the prices will come down, but let's not, the way I frame it is, we have these geese that are laying golden eggs, and those golden eggs right now are very expensive. but we don't want to kill the geese because the eggs are expensive. What we want to do is figure out how we bring this expense down and how we make access equitable. And we had conversations about that, critically important. I know I'm keeping you guys away from a reception. So.
No, Tom, Mark, that was a lovely question. I'll finish with one just last question before we wind up. And Marco Greco, is our president, opened the Congress with the analogy of saying that in terms of legitimizing the concept of patient engagement, we'd got to the moon, but that we were sitting in our spacecraft and not necessarily willing to get out and go explore without wanting to engage in a space race with the USA, because we're not going to win that. What would you say is one last thing in terms of getting out of the spacecraft that you feel that the patient movement in the US has achieved?
I think probably the most important thing we've done in the last 3 or 4 years is we've begun to partner more closely with other stakeholders. We've had a long-term relationship with industry because we've wanted to drive innovation. We've now pulled the payer community in, the provider community in, the hospital community, the researchers, and that's created a lot of benefit. And when you look at those 3 changes, the explosion of people with chronic conditions, that's impacting the payer system. When you look at the high-cost, super high-value products that are coming to market, that's impacting the payer system. And those 2 are dead on for them, and they want to provide them. Your payers in your countries, they want to provide these high-value treatments. We have to figure out how we do it. And that means stretching way beyond our current thinking. You know, we have a model now in Massachusetts where we're looking at these high-cost treatments and how we reinsure them across different payers. Because in the US, you're only with the same insurance company for about 1.5 years. And you go to another insurance company. So what is the incentive for that first insurance company to spend $400,000 to cure you? 0. We have to think very differently about how we do this. We have to think about how we reinsure across governments. I think we're seeing some creativity. We need to encourage that, but it means we need to understand and engage these other stakeholders in ways that we haven't done in the past.
Fantastic. That call to arms to be able to reach out, and that's certainly been part of what we've been looking at over the last 2 days. On that note, Mark, I would say thank you very much once again for fantastic presentation.
Thank you.
Okay, so we've had a really busy day, and one lesson I'm going to take home is that we need to work together, and we need to turn around and look at the margins and give a hand to those who don't already have a voice. I ask that you reflect on 1 or 2 lessons that you've learned throughout the day. I would like to ask, do you like to ride motorcycles by chance? There we go. So I wanted to put special thanks to the EPF youth group who throughout the day and last night have been doing a fantastic job looking at role plays and talking about patient involvement and engagement in healthcare in a very creative way, and I particularly have really enjoyed it. Before I forget, before I end, I've been asked to remind people, please do not take the cartoons off the wall until you've asked Emily from the EPF group, please. You can have them, but we need to scan them and make sure that they're going to the right people. Without further ado, it is the end of the day, and I'd like to thank everyone who has spoken and everyone who has participated, so everyone in this room, and I hope you have a lovely evening. Thank you very much.